Hello everyone and welcome to our short video on common infectious pediatric ENT conditions. Today we'll be doing a brief review of the anatomy and physiology of the respiratory tract, and then we'll be talking about upper respiratory infections, tonsillitis, strep throat, and two types of ear infections. We typically divide the respiratory tract into the upper and lower tracts. The upper tract consists of the oro or nasopharynx, the larynx, and the upper part of the trachea, whereas the lower tract consists of the lower part of the trachea, the bronchi, bronchioles, and alveoli. So let's get into upper respiratory infections. Upper respiratory infections are by far the most common acute illnesses that we see in children. The age of the child, the season, their exposure, such as attending daycare, and pre-existing medical problems all influence the etiologies that we see. The vast majority of URIs are caused by viruses. These can include RSV, rhinovirus, enterovirus, and the others listed here. While it is much less common, bacteria can also cause upper respiratory infections. Examples include group A strep, Haemophilus influenza, and pertussis. The clinical manifestations of upper respiratory infections are listed here. We can see fevers up to 103 or 105 degrees Fahrenheit, and this usually results in some fever phobia for the parents. In addition, these kids typically feel terrible. They have headaches, they don't want to eat, have decreased activity, nasal congestion, rhinorrhea, cough, sore throat, all of these. When we do our physical assessment of the child with the URI, we're predominantly looking at their respiratory effort. How quickly are they breathing? Are they using accessory muscles or retracting? Are they nasal flaring? And of course, we'll also measure their oxygenation with their pulse ox. We're also going to look at the child's activity level of comfort, and then we'll be listening and asking more about the quality of cough and whether or not they're wheezing. On our physical assessment, we'll usually see rhinorrhea and make sure to note the color. In addition, their throat may be red, including their tonsils, and some viruses cause tonsillar exudate as well. Also, their cervical glands may be enlarged and tender, and especially after a fever breaks, rashes are very common with viruses. The treatment for viral URIs largely is just supportive care, which consists of comfort, which includes Tylenol and Motrin if they're older than 6 months old, hydration, humidification or moisture for the respiratory tract to help ease their respiratory effort. We typically tell them to use a humidifier in the patient's room, hold the patient in the shower with them, or use saline nasal sprays or suctioning. You also want to provide nutrition, and we do not recommend over-the-counter cough and cold medications for anyone of younger age. The most common potential complication of a viral URI is otitis media, which we'll be talking about later in the presentation. Much less commonly, we see dehydration, sinusitis, and pneumonia. In fact, less than 5% of patients in pediatrics end up with either pneumonia or sinusitis as a complication of respiratory infections. Tonsillitis is much less frequently seen as well, and this usually falls under the heading of viral URI. The tonsils are masses of lymphoid tissue in the back of your throat, and they tend to help filter organisms as well as play a role in antibody formation for your immune system. When the tonsils become inflamed, it's usually due to pharyngitis for the same causative organisms that we talked about with viral URIs. Clinical manifestations are exactly what you'd expect with inflammation of the tonsils. They'll be red, sometimes they will or will not have exudate, and they'll also be swollen. As with any virus, the treatment for viral pharyngitis is just supportive care, which we talked about on the previous slides. For bacterial pharyngitis, we typically only treat streptococcal bacterial pharyngitis, and so this patient would need a strep test. We'll be talking about strep throat next. With recurrent infections or massive enlargement of the tonsils, patients will usually see ENT to have their tonsils and/or adenoids removed. There are important complications of tonsillitis that we want to be on the lookout for, such as the development of a tonsillar abscess. So if you look in the back of the patient's throat and one tonsil is predominantly larger than the other, they may need additional imaging, and if they have an abscess, it has to be drained by a trained ENT physician, and they may require IV antibiotics. Now let's move on to strep throat. Strep throat, or streptococcal pharyngitis, is caused by group A strep. In itself, it's not a serious disease, but we treat it with antibiotics to prevent some of the sequelae, such as acute rheumatic fever or acute glomerular nephritis. Usually a course of strep throat is a brief illness, and it can vary in severity from having no symptoms whatsoever. In fact, if you were to swab 100 people on the street, 5 would come back positive for strep and not even know it, all the way up to severe toxicity. We've seen patients in septic shock because of group A strep. The onset is usually abrupt, and it's characterized by a common group of symptoms. Sore throat, headache, fever, abdominal pain, and vomiting are by far the most common. In addition to having these little red spots that you can see in the picture here, redness and exudate is also very normal. Also, anterior cervical lymphadenopathy is normal as well. Again, 80 to 90% of all cases of acute pharyngitis are viral for the reasons that we talked about before. However, to make sure that it's not strep, we do a rapid streptococcal antigen or molecular testing. If the antigen testing is performed, we also do a follow-up throat culture. If you've had strep before or you have signs of complications, we can do a serum ASO test. When we treat strep throat, we want to treat the pain with either Tylenol or Motrin, encourage hydration and nutrition, and then give antibiotics to kill the bacteria. The first-line antibiotic is amoxicillin. For patients who have a penicillin allergy, we can use cephalosporins or macrolides as well. Moving on to otitis media. Otitis media is inflammation of the middle ear. Acute otitis media is inflammation with the middle ear that is also associated with ear pain and fever. Otitis media can also be viral or bacterial. The most common bacteria are listed here. Predisposing factors include URIs. In fact, like we said earlier, otitis media is the most common complication of a URI. But really anything that causes secretions to be present in the middle ear can cause otitis media. So that would include allergic rhinitis, going to daycare, which exposes patients to pathogens that get them sick with URIs, and exposure to secondhand smoke. The pathophysiology of acute otitis media is actually quite simple. The middle ear, which you can see in this picture here, is filled with secretions. And the eustachian tube, which you can see at the bottom, which is supposed to drain the secretions from the ear, is inflamed, narrowed, and in children also horizontally oriented. Therefore, the secretions don't drain, pressure builds up, and anything that stays sitting for too long can colonize with bacteria. Clinical manifestations of acute otitis media, as we said earlier, typically follow a URI infection, and they include fever, ear pain, and sometimes, especially if the tympanic membrane ruptures, purulent discharge. In addition, you'll see constitutional symptoms such as fussiness, irritability, especially when worse at night, and pulling on the affected ear. Diagnosis of otitis media is made based on several factors. Basically, we look to see, is the eardrum red? Is it retracted or bulging out at us? And is there a effusion inside there? If there isn't an effusion, what color is the fluid? Treatment for otitis media is similar to strep throat. We start with high-dose amoxicillin. Second-line antibiotics, if the amoxicillin doesn't work, or if the patient is allergic to amoxicillin, can include those listed here. If the patient refuses to take oral antibiotics, or if the patient has failed several oral antibiotics, we can use IM Rocephin as well. For children with recurrent ear infections, we can also have the ENT physician insert tympanostomy tubes, which not only allow drainage and equalize the pressure, but we can also use these tubes later on to directly instill antibiotic drops. And finally, we'll talk about otitis externa, or swimmer's ear. Normally, the external ear canal is protected by a waxy and water-repellent coating. However, when this coating is interrupted, such as during swimming, we can see bacteria that are commonly found in water growing in there. These bacteria can cause infection, which then causes the ear canal to become irritated, macerated, and to produce drainage. And here's a good example of what the drainage looks like. The predominant symptom of swimmer's ear is external ear pain that's worse when you manipulate the ear. Sometimes hearing loss can be present either due to edema or the amount of secretions or both. And edema, erythema, and discharge is usually seen inside the ear. Because this condition is present on the external ear canal and not behind the tympanic membrane, we can treat it effectively with antibiotic drops. We also treat pain with Tylenol or Motrin. And thank you for your kind attention today.